welcome Professor Martin Curley. Professor Martin Curley is Digital Director Transformation, or Director Digital Transformation HSC. He is recognised as a global thought leader in open innovation, European CTO of the year 2015. Professor Martin Curley's strong experience in advanced IT delivery innovation in multiple domains makes him a much sought after speaker on technology, innovation and entrepreneurship. Recent accomplishments include a successful digital transformation of the Irish healthcare system to deliver better health outcomes and stimulate significant economic growth. So I'm delighted to welcome Professor Martin Curley, who will discuss Innovation 2.0.
Great. Conor, thank you for the kind introduction, and good afternoon, everybody. It's a privilege to present. I'm going to talk about two things. I'm going to talk about Open Innovation 2.0 as a new methodology for digital innovation or digital transformation. And as I looked at the video from Sandyford Business District, I think Sandyford Business District is already a brilliant example of Open Innovation 2.0 at work. But to make it real, I want to show how we've been using this methodology to digitally innovate in response to COVID-19. So if we can go to the next slide, please. So the digital transformation function was founded about a year ago. And what we have done is create a new digital innovation pipeline. Typically, IT change at the HSE has been very slow and cumbersome and taking it multiple years for digital changes to be implemented. Well, we've created a new digital innovation pipeline using the principles of Open Innovation 2.0, and I'll share some of those with you later on. If we could have the next slide, please. So we have a 10-year roadmap to take Ireland from being a digital health laggard in Europe to a digital health leader. The OECD published an excellent report last year, Healthcare in the 21st Century, and it said that healthcare was on average about a decade behind most other industries in adopting digitization. And also the data in the report showed that Ireland was several years behind actually mainstream Europe in terms of adoption of digital health techniques. Our goal is to be a European digital health leader in 5 to 7 years, but through COVID, we might accomplish that a little bit earlier. If we go to the next slide, please. So I want to give you a whistle-stop tour of our digital transformation strategy before I talk about Open Innovation 2.0. There are 5 things that we're working on, and they work hopefully as a virtuous circle. We have a digital academy, and we co-designed and co-deliver a new master's in digital health transformation, and all 8 professors from all 8 universities in Ireland have been involved in the design of that, but also in the delivery. We're currently open for application, so anybody's listening to that, I'd encourage you to apply at hscdigitaltransformation.ie. And so far, we have 400 expressions of interest for 50 places, so competition will be quite hot. We manage a portfolio of about 50 digital innovations, and we're managing them through 4 different phases from idea to broad adoption. And I'll share some examples of that in the presentation. We have a digital innovation strategy called Stay Left, Shift Left. I'll talk about that in two slides ahead of this. And we've also created a new fora, which is kind of like TED Talks for digital health, called the Digital Academy Fora, where we share, spread and solutionize on new ideas. So if we go to the next slide, please. And then the next slide. So this is a pictogram of our digital innovation strategy. It's very simple. It's called Stay Left, Shift Left, but because of its simplicity, we have got sort of tremendous pickup from the ecosystem. So we're using this to orchestrate the national digital health ecosystem. And this is a key characteristic of Open Innovation 2.0, where there is a shared vision that all elements of the quadruple helix, and that by that I mean government, industry, academia, and citizens or patients participate in, when you have a core principle of Open Innovation 2.0, when you have a shared vision that is shared amongst the four elements of the quadruple helix, you can drive structural changes far beyond the scope of changes that can be accomplished by any one organization or individual on its own. The strategy is very simple. Stay Left is about allowing people who are well to stay well in their homes, or if you happen to have a chronic condition, that you can be managed best of all at home. Shift Left is about moving people as quickly as possible from an acute setting to a community setting to a home setting. One very good example of this, which I'll elaborate on a little bit more, is remote monitoring of COVID-19 patients. Initially, if you had COVID, you were automatically hospitalized. But in the space of 3 weeks, we went from an idea to a solution that was being prescribed by our hospitals, in that a patient, if they had mild or moderate symptoms, was sent home and remotely monitored from their home using an app and a Bluetooth-enabled pulse oximeter. But more on that a little bit later. If we could move to the next slide, please. So Open Innovation 2.0 is what we call the new mode for digital innovation. And basically, we have all the actors working together, and there's a new primordial soup, which consists of digital assets, is connected by digital assets and allows the creation of new digital outputs. If anybody's interested in more detail, I published a piece in Nature a couple of years ago on Open Innovation 2.0, and there's also a book I published with a colleague from the Commission, Broer Salmon. And so let me give you a case study of how the HSE has responded to COVID-19 using this methodology. So if we go to the next slide, please. So there's a fine book published by Larry Downs and Paul Nunes a couple of years ago called Big Bang Disruption. And this talks about the normal adoption cycle of a product or service being significantly compressed and the adoption happening as a big bang. And I believe we've witnessed this quite a few times now in the HSE, where programs normally would have taken 2 to 5 years. We were actually able to implement them in a matter of 3 to 4 weeks. So if we go to the next slide, please. This was an example of our digital transformation pipeline. We have 4 phases: exploration, proof of concept, demonstrator, and then broad adoption. So this was a newly established group. So this is what the pipeline looked like around February. If you move to the next slide. So after the first wave of COVID, so this is probably a snapshot from about June. This is what our pipeline looked like. We had many more proof of concepts. We had more demonstrators, but most importantly, we had a number of applications and solutions that were broadly adopted. And I'm going to talk about some of those examples. So the next one, please. So we opened up a solutions portal and we looked for solutions, and we had big companies, small companies, academics submit ideas to the portal for digital transformation, and we'll give some examples of these now. Next slide. Probably one of the ones we're most proud of is our remote management of COVID-19, and this is the home monitoring solution. And at its peak, we had about 1,000 patients being remotely monitored from home. When we talk about stay left, shift left, we're looking for 4 characteristics of change. We're looking for improved quality of care, reduced cost, improved quality of life, and improved clinician experience. And I'm delighted to say for this app, we hit all 4 of those criteria. We announced this. I was giving a talk at the IIEA, I think in March, and I presented the working prototype of this app with the pulse oximeter, and within 2 weeks we were prescribing that solution to patients in different hospitals, and we went from idea to the solution being prescribed in over 30 hospitals and assessment hubs in 5 weeks. So we were able to move very quickly. Normally that process would have taken about 2 years. If we move to the next slide, please. A simple innovation, but a very important one, was the use of non-contact digital infrared thermometers. So we moved quickly on these, and we were able to introduce about 10,000 of these thermometers into the healthcare network. And they were important because they minimize contact between the nurse and the patient, which reduce contamination risk. But importantly, they turned out to be a fifth of the cost of the standard total cost of ownership compared to the existing thermometers that were being used across the healthcare system. And we see this as a characteristic of digital. Very often we see a 10x improvement in capability or a 10x reduction in cost. In this case, it was 5x, but it was very significant. Next slide, please. In the very early days of COVID, we mobilized quickly with a company called RedZync from the Digital Hub. And, weeks and weeks ahead of, Teams and Zoom being commonplace in the healthcare environment, we were using the Blue Eye Direct video service to allow consultants, have appointments with mental health patients, and also St. James's Hospital. This is the core solution that they're using. And the beauty of this, it's just a text that is sent to an older person or whoever, and they just click on the text, and without any application, secure two-way video link is created. So this has been pretty effective. Next slide, please. So it wasn't commonplace for doctors to have video consultations or GPs to have consultations with the regular patients. In a period of 48 hours, in the very early days of COVID-19, we worked with two companies, Wallola and Newa Health Solutions, and in 2 days they had actually stood up two patient communication portals. We went live with them, and within another 48 hours, we had over 600 GPs and clinics signed up on both platforms. So we went from zero adoption to a big bang adoption in 4 days. Next slide, please. The next innovation wasn't a technical innovation. It was already possible to send a prescription electronically, but unfortunately it wasn't legal. So we pulled together together with the Department of Health, HSE Digital Transformation, pulled together a couple of meetings with key stakeholders. So the IPU, the Pharmacy Union, the ICGP, the Irish College of General Practitioners, and also one of the big suppliers, Plan William. And very quickly we converged on the solution that we had to enable electronic prescriptions. So some secondary legislation was introduced in the Dáil, and on the first day, we had just a handful of prescriptions transferred electronically. But by day 3, we were seeing a volume of about 10,000 prescriptions being transferred electronically. And this is another example of big bang adoption. And it was very important. So people didn't have to handle a piece of paper that potentially could have been contaminated with COVID-19, and it could all be done electronically. If we could move to the next slide, please. Another solution that was developed very quickly is a solution called Accord, and this was designed over a weekend in Beaumont Hospital. I had the privilege to be in with 4 or 5 respiratory clinicians that designed this application, and essentially it was to allow both expert and non-expert consultants and hospital doctors manage patients with COVID-19. And essentially it was developed at the time we were all seeing the horror pictures coming in from Lombardy, and it allowed predict 12 hours in advance which patients would need ICU care. The solution is adopted in 6 hospitals, but it's currently been held in reserve in case we get an escalation of hospital cases of COVID-19. Next slide, please. A real breakthrough technology, a disruptive technology that we deployed is from an Irish company called PMD Solutions, RespiraSense. And this has been deployed in Beaumont and Cork University Hospital, and it's been revolutionary. One of the measurements that are most often wrong are manual respiration rates conducted by nurses. And in our study in Beaumont, it showed that over 80% of the manual respiration rates were incorrect. But much more importantly, during the COVID-19 period, having this sensing technology on patients, significantly reduced the need for PPE and to have nurses continuously checking on patients. And we also were able to see predict about 12 hours in advance which patients were going to deteriorate and potentially need ICU or intubation. So we're looking to try and get the solution implemented nationally now. We've gone from a pilot to a demonstrator very quickly. Next slide, please. One thing I want to say, and this is Open Innovation 2.0 in practice, even though we were innovating, heavily for COVID-19, we also got on with some of the core business. So we set up a network of HSC digital labs, which I'll talk to you about in a second. But each of our innovations goes through 4 phases: an exploration phase, a pilot phase, a demonstrator phase, and then a broad adoption phase. And these correspond to the 4 levels of clinical trials. You will have heard people talk about, the vaccines moving to, level 3, clinical trials and so on. But we have the same for digital solutions. And if we move to the next slide, please. One of the key concepts in our digital labs is the concept of a living lab. And I think what Sandyford Business District actually is a really good exemplar of a living lab, and is a key feature of Open Innovation 2.0. A living lab is a user-centered open innovation ecosystem and environment, often operating in a territorial context like Sandyford, and really impressive numbers in terms of the amount of Fortune 500 companies that are located there and the number of employees. A living lab is about integrating concurrent research and innovation processes, and this is achieved within the context of a public-private people partnership context. Next slide, please. So last week we were very pleased to announce publicly 10 new living labs spread across the country, from Sligo to Cork to Roscommon to Wexford to Cavan to Dublin. One of the ones we're most proud of is our vital signs automation living lab in Cavan, and that has recently moved from, or is moving from, a proof of concept to a demonstrator. One of the most important things that is used to monitor a patient when they're in hospital is something called the NEWS, the National Early Warning Score. This is something that is measured and manually calculated by a nurse, and there's about 49 opportunities for error in that score. And when we've done the analysis, about 50% of the NEWS scores are incorrect. So can you imagine running a factory where 50% of your main KPI for your product is inaccurate? Well, unfortunately, that is what happens today in Irish hospitals through no fault of the nurses. And what we've been able to do is implement a vital signs automation that takes those errors to zero. So what we're now doing is making sure all of the wards in Cavan General Hospital are running this technology, and we hope to make the business case for broad adoption across the network. So I'm almost finished. I'm conscious of the time. If we could just move to the next slide, please. So one of the living labs that we're working on at the moment is to create a COVID-19 health passport. And here are some screenshots. We're working with a company called Roku, who have been developing, who have been testing using rapid antigen testing. And Ireland is quite a ways behind in terms of using rapid antigen testing, but the adoption of that is a decision for the clinicians and consultants. But I'm delighted to hear today that NEFIT has stood up a working group to see what we should do around rapid antigen testing. But this application is something that you would download to your phone, and another person can actually scan the QR code to give your status. I conducted, or a live test was conducted on me a couple of weeks ago, a rapid antigen test. The results were available in 15 minutes, and you can imagine how revolutionary this could be if it is adopted in Ireland. Germany have purchased 9 million of these a month. The US have spent 790 million on rapid antigen testing, and countries like Italy and France are adopting them. So hopefully it won't be too long before Ireland adopts them. But in the US rollout was bedogged because they didn't have a digital platform, but we're hoping to have a digital platform in place before the rapid antigen test gets rolled out. So next slide, please. Another living lab that we've had that's been proved quite effective is mobile X-ray for nursing homes and private homes. So instead of bringing a patient to a hospital where there could be a risk of COVID-19 contamination and having them wait for 6 or 7 hours on X-ray and results, the X-ray machine is brought to their home or their nursing home, and it has proved a very effective um, use case. So we're hoping that we might be able to broaden this from a pilot to a demonstrator. If we just go to the next slide, and I'll try and wrap then. One area that we've been progressing as well is the use of ultraviolet cleaning. We currently have a proof of concept living lab in Tullamore General Hospital, and the early trials from here and from the proof of concept in the Mater Hospital is it's extremely effective in killing COVID-19. And it's also extremely effective at killing MRSA and other superbugs. So just to summarize, Open Innovation 2.0 is a new methodology. We've kind of pioneered it with the European Committee or European Commission and developed sort of key practices and principles. The HSE is a leading exponent of Open Innovation 2.0. I think Sandyford Business District, without actually really recognizing it was doing Open Innovation 2.0, is a great exponent of it, and the results seem to be very significant. We have a single integrated digital strategy, stay left, shift left, which the whole ecosystem have got behind, and we've been able to deliver some extraordinary results in a very short space of time. I would mention it's not easy because most management organizations are designed to be resistant to change. And Eric Topol, he's a renowned cardiologist, and he talks about medicine being extremely resistant to change. So we've had to use some guerrilla tactics to actually get some of these innovations across the line. We use the Nike mantra, just do it. So we look for forgiveness than seek permission, because if we'd sought permission, we certainly wouldn't have got some of these innovations across the line. So I wish Sandyford Business District all the best and look forward to continuing collaboration. Thank you.
Professor Martin Curley, thank you very much. It's clear and very obvious that the HSE is undergoing huge transformation. Some really valuable insights you gave us. So we hope you can